Then you will get the answers directly from the first presentation. Dr. Nilesh, you are going to present on which topic?
The first case will be of glaucoma, sir. And since we are starting for the first, all the other cases are going to be short. We are showing the picture and then presenting. So I thought the PGs might benefit to show how a glaucoma case history should also be presented during examination. This is a case which I presented during my residency when I was first year of diploma student. So I thought I will take that presentation and present it again. So the female patient presented with a loss of vision in left eye since 7 years and whitish discoloration of the black part of her left eye since last 6 months. The patient was apparently asymptomatic 7 years back that she noticed blurring of vision in her both eyes, which was sudden in onset, non-progressive and painless. It was associated with episodes of vomiting, giddiness, generalized weakness and pain in lower limb. She used spectacles lying around in home for symptomatic relief and was treated for other symptoms by family doctor. 2 days later, she had an episode of fall. She was unable to get up and then she was brought to the hospital. She was brought on the same day and she had LOC for 8 days and admitted in comatose state in ICU for the 8 days. During her stay in the ICU, as per her relative, she was evaluated by ophthalmologist and was started on some medications, details not known. As per her medical records, she was diagnosed to have viral encephalomeninger radiculopathy. Once she regained consciousness, she could not perceive any light in her left eye and was diagnosed to have optic neuritis. She was started on oral and topical medications and was discharged. On follow-up in ophthalmology OPD, she was found to have consistently high IOP and she was admitted for IOP monitoring and then was started on anti-glaucoma medication. Subsequent follow-up showed persistently high pressure and she was on a mix of multiple therapies and then left eye cyclocryotherapy was done for palliative relief. She started to notice on and off redness in her left eye following the surgery, which had no fixed pattern. Further follow-up again showed raised IOP in her left eye and was told about necessity of other surgery, and 3 months later she underwent AGV implantation and was discharged again on oral and topical steroids. Steroids were tapered over next follow-ups. She now comes with complaint of whitish discoloration of the black part of her left eye, which was noticed by bystanders 6 months back, small pinnet sized, which is gradually increasing, and she visits us now for further evaluation and management. So no history of headache, no pain, for current episode, no history of headache, pain, redness, watering, backache, joint ache, skin lesion, recurrent blood transfusion, ocular trauma or similar complaint in other eye. No history of similar complaints in past. No, she is not a diabetic or hypertensive, not a known case of TB, asthma, cardiac disease and any other chronic medication. Coming to examination, she had 30 degree of exotropia in her left eye and facial symmetry is slightly asymmetrical with left side looking little shrinked. Extraocular movements were normal. Visual acuity was PL negative in her left eye and normal in her right eye. Dry retinoscopy showed no significant refractive error in right eye. And coming to the anterior segment diagram is very important for postgraduate. It has to be documented in each and every cases. This is the slit lamp picture. Right eye is almost normal. Left eye she is showing a whitish discoloration in involving central, paracentral and peripheral area with limbal vascularization, which is linear in pattern with some kind of looping. And also we can on the conjunctiva we can see the tube that is extruding from the anterior chamber via the sclera and in the subtenon space, probably the IMAT glaucoma valve that has failed. Right eye fundus shows a little bit of increase in CD ratio. CD ratio vertically is oval, it is 0.4 with slight inferior notching. Left eye, no fundus was visualized. Aplanation tonometry in right eye was 18 mm of mercury and left eye was not recordable with aplanation. Digital tonometry showed T3 minus, that is a soft eye. Gonioscopy was with high level of pigmentation in right eye. Left eye gonioscopy was not possible. No significant visual defect in right eye. Axial length was reduced in left eye. It was around 18 mm. So diagnosis will be left eye phthisis bulbi with query band keratopathy and right eye glaucoma suspect. So the questions that usually are asked in the viva are, what is the relevant drug history for a glaucoma suspect, ma'am? So, what should the PGs tell? Which are the prominent glaucoma and the drug history that should be taken for a glaucoma patient?
So in this patient, see the patient was getting recurrent episodes of loss of vision, vomiting and all that. So whether the patient was giving, whether, in darkness the pupil was dilating, it was an angle closure attack, and how the attack was getting relieved. And there are specific drugs like, the cost of the drug itself for glaucoma, the duration of the drug. The patient, always the doctor would have told the patient ki aapko kalia motia ya kuch hai. So, history itself tells you the diagnosis in many cases with regards to glaucoma and the type of glaucoma, because open angle glaucoma is symptomless and angle closure glaucoma is the one which presents with pain, that itself. Because open angle glaucoma patient would come at the late stage with loss of vision, which would be detected very late. Whereas an angle closure glaucoma is the patient where the patient has symptoms. So angle closure glaucoma is symptomatic, painful, and open angle is non-symptomatic. So these are various indications which may help you.
Basically, if you have seen this case presented, patient was there in the ICU. Before that, 7 years patient is complaining of diminution of vision. So that time there is no any detailed history, only vomiting and everything is happening. So we don't know what was that. When admitted in ICU, after that she was also diagnosed at the neuritis, and after neuritis she has been given the you can say steroids.
Yes, sir.
And these steroids can be one of the cause of the glaucoma. But here if you see, it is one of the cause of the glaucoma. In the left eye it is a completely blind eye. In the right eye, yes, there is a, you can say 0.5, 0.6 CDR is there. So one thing is she may be a steroid responder, and this steroid responder persons can have the glaucoma, you can say, in the patient, and already there is a history of the steroid consumed when patient was in ICU. But see, relevance is not happening in the history. So that patient is a blind and having the episodes in 7 years. And after that there is another big episode which was general episode, and then the patient is blind by the left eye. So, and even in the angle now, left eye angle is not possible to see, but that history suggests patient may have the closed angle glaucoma, and that might have caused all these episodes. And these episodes, there is no history of redness, only vomiting and everything history is there. But in the closed angle glaucoma, there is also history of redness.
The history, the initial history is giving the clue that it appears like a narrow angle glaucoma, wherein there is a sudden reduction in visual acuity, pain, headache, etc. I will agree with sir that there is some redness as well in these cases, and blurring with, as you said, in the history it was very clearly mentioned that there is some haziness, whitishness in the cornea as well. This means there was some edema in the cornea. So that is suggestive that it was a case of a narrow angle glaucoma. As far as the relevant drug history is concerned, again, steroid is something which is which can aggravate, but most of these are two mechanisms actually. You can have a mixed mechanism glaucoma as well, but they are two mechanisms. Most of the steroid responders, the angles are mostly open in these cases, and typically pigmentation as you showed.
Yes.
But you did not mention about the exact status of the angle. How much was the angle open? What was the degree of?
Yes, sir. I skipped through that, sir, because.
Because in right eye it was visible.
Yeah.
So we should also know about the angle status.
Yeah.
That will also give us an idea. But the history that was suggestive initially was, and the patient was not on any steroid earlier before the history.
Yes, sir. No, before on ICU admission she got topical.
No. First time when the patient had
No, sir.
had
No
there
history.
was no history of
steroid
steroid.
intake.
So then it was not a case of steroid responder. Rather, it was a narrow angle glaucoma, typically presenting with blurring of vision, some haziness in the cornea, corneal edema, and pain, vomiting, headache. So that was typical of a narrow angle
Yes.
glaucoma.
So
Proceed. our
Yes, sir.
answers.
So the relevant drug history, as it is told, most common is corticosteroid, systemic and topical, and then there are multiple other things that can aggravate angle closure glaucoma, like anticholinergic agent, topical atropine, cyclopentolate, tropicamide, or systemic antihistaminics, antipsychotics, anti-Parkinsonism drug, and adrenergic agents also can induce similar angle closure attacks. So the next question will be, what are the clinical findings that warrant glaucoma investigations?
So the clinical findings will vary depending on whether it is an angle closure glaucoma or an open angle glaucoma. In an angle closure glaucoma, you will have iris atrophy, glaucum flecken, and say maybe an oval pupil. And in a say open angle glaucoma, because it is detected at a very late stage, there may be a sluggishly reacting pupil, and otherwise if it is a primary open angle glaucoma, then there will be nothing visible in the eye. So these are the things, like already the answers are.
In that eye is a hello. Yes. Hello.
This one is working.
In this, I think the what you have written is correct. See what happens. You go behind your question. Now, what are the clinical finding that warrants the glaucoma investigation? Go next. See the clinical finding. You are very correct in the poorly reacting pupil. Yes, the relative afferent the same. The pigmentation on the iris, the glaucoma flecum, smaller anterior capsular opacities, vertical enlargement of the disc, and the difference between the cup and tube,
Yes.
CDR, difference of CDR in the both eyes. That is also very important finding. May not be much more, but one is 0.3, other is 0.4. That can also definitely one of the, you can say, sign. Then the pupillary atrophy, yes, you can see in the closed angle glaucoma. The RNFL defects, yes, raised intraocular pressure, that is also this one. And also if you see these all clinical signs are there. Then in the symptoms also, delayed dark adaptation. If patient is having the delayed dark adaptation, that will also the one of the, you can say, the symptom that can help. So once you know these signs, another thing here remain, when you have seen all these things, then you can ask for the family history. Is there any family history in the this one that patient are carrying? That can also be added. So I think clinically you have written everything. In that we should also see that yes, in all these things there can be a glaucoma.
Yeah, I think everything is complete. Just one thing, maybe if it's the first attack of acute angle closure, and once the cornea clears up and you examine the disc, you may not have a large cup during that period. After multiple attacks, you get all
Yes.
that large cup. So that is something that may be variable. But even if it's not there, other things are there. One should investigate for the glaucoma.
For PGs, one thing is very much important. At least you check the shallow AC. If either you can test it by torch or by Von Herrick's, whatever the thing available to you, just go for the shallow AC is the most important among all the factors. So check for it.
And one of the most common question that is asked is, what is the principle of aplanation tonometry? A theoretical question, but most commonly asked in Viva. So it is based on Imbert fixed law, where the pressure is equal to the force applied by the area applanated, and it has been now adjusted with CCT also.
Yes, very true. And one more thing that Dr. Rajesh Bhai said is very important, is that the cupping will happen at a later stage. So it is only in chronic angle closure glaucoma that there will be cupping. Otherwise, in any angle closure glaucoma like acute angle closure and all that, there will be no cupping. So in a chronic angle closure glaucoma, there will be cupping, and in open angle glaucoma, there will be cupping. So to differentiate whether it is open angle or closed angle, you have to do a gonioscopy, because the treatment will vary. In open angle glaucoma with cupping, the treatment will be medical, and in a closed angle glaucoma with cupping, because most of the angle is closed, then you have to see whether it is appositional closure or whether it is cynical closure, and the treatment is basically surgical. So even when there is a cup, you have to do gonioscopy or you have to do OCT angiography, I mean anterior segment OCT, even advanced to see. But gonioscopy one must all know because the treatment is completely different for these two type of patients.
So then next questions are what are the factors that will be affecting IOP?
Already you have written that the factors affecting. In that you have written demographically age, yes, definitely in age it affects the sex, race, heredity, you are correct. The systemic you can say diurnal variation, yes, very important that whenever you are taking the intraocular pressure, if you are taking at once, that is also diurnal is better. Seasonal variation, blood pressure, yes, with it increases with the hypertension. Postural exercise, Valsalva maneuver, and the ocular refractive error. Now here we'll have to write about the thickness of the cornea.
Yes, I indirectly I meant the myopia will have.
But not myopia. You
and
get
hyperopia will have
keratoconus.
shallow AC.
You get keratoconus
Yes,
also.
sir.
You get hypermetropia also.
Yes, sir.
So you'll have to go for the corneal conditions, hai na?
Yes.
In the if there is a corneal opacity, then if there is a hypermetropia, it means cornea is thicker or cornea is thinner. So that definitely affects, and in that you'll have to change the, you can say, procedure by which you can say the technique by which you are measuring the intraocular pressure. So you'll have to add the corneal conditions here, and then the fluctuation is extraocular movements, eyelid movements, squeezing of the patient. Yes, all these things definitely add in the intraocular pressure. I think you are correct. Any you want to add anything?
Nilesh, that is the difference when we are thinking that and what is in expert mind.
Expert mind
that is
says.
the session's target that we are showing, thinking that as a resident that if we say refractive error, it indirectly or directly correlate with CCT or other thing. But examiners want to, you have shown
Yeah.
number of demographic factors, but Professor Lane has chosen only 4, 5,
Yeah.
which is the key: age, hereditary, diurnal variation. So these are the things we have to know, and we only can know as long as we listen and being examined by some examiner.
I think CCT is a very, very important point which sir had
Yes, sir.
emphasized.
So then we'll come to what are the classical visual field defects in glaucoma. I'll just run through what it is and then we'll ask the experts. So the initial one is the paracentral scotoma that we get. It is on 30-2, and then we move on to 24-2 where we have nasal stepping, a dark, a more concentrated nasal stepping, and then we have an early arcuate defect, dark arcuate effect, and then a double arcuate sign. And once we have deep double arcuate sign, we don't have too much of points to be analyzed. Then we move to 10-2 where we can see the double arcuate sign, but some area is being now, we can see it is clear. Then that also goes off. Then we come to macular splitting. So, sir, anything else and any?
All things are there, but Rooney's nasal step is not there. Rooney's nasal step.
Yes, sir.
And is very important because the Rooney's nasal step clinically it is important. See what happens, because the fibers which are there, they never cross the macula, so they are arcuate fibers are seen, and because of that you see the Rooney's nasal step. And the I think the all others, the temporal small Iceland remaining, and the
Yeah.
you can say the tubular visual field, that can be also added.
Yes,
One
sir.
is the tubular visual
Visual
field,
field.
then the temporal small Iceland of
Yes,
this,
yes, sir.
and you can say Rooney's this one, you can add in that.
Yes.